Hello, everyone. Thank you very much for joining us today for our treatment option fibroid educational webinar. We are very excited to have three physicians joining us today from Avina Women's Care. And we are going to have a presentation that is going to be shown to you throughout by each of the physicians, but we want to encourage you to make this a conversational experience. So if you have any questions as the physicians are going through the presentation, please feel free to type into the chat your question, and I will be sure to address it with the physicians as we go through the webinar. We'll also have information that's in the chat of how you could schedule a consultation with any of these three physicians so that you can see them after the webinar is finished. I'm going to turn it over to you, Dr. Adkins, so that you all can do introductions.
Hi, I'm Dr. Leah Adkins. I am initially from Ohio and moved out of state for residency. And when I came back, my first job was in an underserved area south of Columbus for about 4 years. And I've been with Avina Women's Care in Columbus for the last 13 years. So I'm excited to meet you all tonight through this virtual webinar.
Hi, everybody. I'm Dr. Brianna Donlon. I did my medical education in Wisconsin, where I grew up, trained at Ohio State. We've been in Columbus for about 12 years now. I joined Avina Women's Care right out of residency, and I'm just starting my 9th year in practice. And I do a pretty even split of obstetric and gynecologic care, and I have a little bit of a subspecialty focus in robotic surgery.
Hi, I'm Dr. Tracy Cook. I am also sort of homegrown here in Ohio. So I went to Ohio State Medical School and residency at Riverside Methodist Hospital and joined private practice immediately out of residency in 1997, which actually is my 27th year of private practice now, hard to believe, but also have a mix of obstetrics and gynecology and just general OBGYN. So super excited to have this new opportunity and to discuss this all with you. So thanks for joining us tonight.
Thank you all very much for being here. So the first thing we're going to talk about is what are fibroids? So let's get right into that.
So yes, what are fibroids? Well, fibroids are the most common pelvic growth in women, and they occur within the uterus. The uterus is a big muscle. And so think of a fibroid kind of like with one of those muscle cells clones itself and makes an extra ball of muscular tissue. And that can cause discomfort, can push on things like the bowels and the bladder. It can cause your periods to be longer or heavier, just crampier in general. And they can occur in different spots in the uterus. So on this diagram, it's a picture of the uterus, and the little kind of yellowish areas are the fibroids. Other names are myomas or leiomyomas, but I would think fibroids are probably the most commonly recognized name that we call them. They can occur within the cavity of the uterus where a baby would grow. They can occur in the muscular wall and push into that cavity. They can occur completely in that muscular wall or on the outer part of the muscular wall and push out to the other pelvic organs like the bowels and the bladder. The submucosal fibroids are the ones that are more in the cavity of the uterus, and those tend to be the ones that make your periods the worst because they affect the lining of the period. They can be completely kind of just attached by a little bit and completely floating inside that cavity, or they can just be within the muscular wall and pushing in. Those are ones that are easier to treat non-invasively by old methods like hysteroscopy, where we can take a lighted camera and look at them and get to them without incisions. They can also affect fertility. So when an egg and a sperm come together in the fallopian tube, that embryo will transfer down into the uterus and attach in the uterine lining. And we don't want them to attach with the fibroids. The fibroids can affect just the blood flow to a growing baby. They can affect just positioning. And so that's one type of fibroid. The intramural fibroids are more within the muscular wall. They can cause heavier and crampier periods as well, bloating. They can push on the bowels and the bladder and cause issues with constipation or urination. And the subserosal fibroids are the ones that are more pushing off of the outside of the part of the uterus. And it can really affect just your day-to-day life. Lots of people have fibroids and might not have any symptoms. But for a significant population of women with fibroids, they're going to miss days off work. I have patients that are teachers or really any sort of profession where they wear black all the time. They're always afraid they're going to bleed and have cramps. And so, but I feel like a lot of my teachers, they're like, I can't be running to the bathroom all the time. And so it can really change just their day-to-day, how they schedule their days, what they wear to work, whether they're taking extra clothes. It can affect vacations and trips. They might bleed for just longer than a week, a month, and it can really affect intimacy. So from a sexual intercourse standpoint, it could be painful, or just people sometimes don't want to do that when there's bleeding.
And Dr. Adkins, can you talk a little bit about if the size of your fibroid, does that impact, the symptoms that you may have and the severity of your symptoms?
Yeah, so depending on the size and the number and the location, it can really change the symptomatology that patients have. They can be small, just like a half an inch. They can be as large as a baby's head. When we talk about the size of the uterus, as obstetricians and gynecologists, we like to refer to the size that would correlate with a certain point in pregnancy. And so sometimes it will look like people are 4, 5, 6 months pregnant because of those fibroids. And the larger they are, the more they're going to push on the bowels or the bladder, the more likely they are going to be to cause discomfort with sex or just normal daily activity. And if they're more inside the uterus, that can affect more from a fertility standpoint.
Thank you.
They're actually very common. So I talked about how they're the most common pelvic mass for women. But by the time you reach menopause, which averages is about 51, 52, 70% of white women will have fibroids if we just scanned everybody, and more than 80% of African-American women will. It tends to be more common in that patient population. And about 25 to 50% of women will experience symptoms. And 2 million women each year undergo treatment for fibroids. One of the things that people ask about is, what causes fibroids? We don't necessarily know what causes fibroids. We do seem to see a connection if they run in the family. So if you have a mom or grandma or sister with fibroids, you're probably at higher risk of having them yourself. So how do you know if you have fibroids? Well, like I said, some people might not know at all. They might have no symptoms. Sometimes patients come in and we're looking for other reasons. And oh, by the way, when we're looking for a cyst or whether their IUD is in the right spot or they're pregnant and we're doing a scan, we might happen to find a fibroid. And if they're small and mind their own business and not causing any problems, it's nothing that we have to worry about. But if you have heavy bleeding, long, painful periods, if your periods are affecting your day-to-day life, or if your gynecologist, when they do your pap smear, feels the uterus and feels like the uterus is enlarged, we're going to say, hey, you know what? Let's look for fibroids as a cause of your symptoms. And the most common way that we'll do that is an ultrasound. There are other imaging modalities like MRIs or CAT scans that you could have. Sometimes people are diagnosed in the ER. They're getting looked at for diverticulitis or appendicitis or kidney stones. And oh, by the way, you have some fibroids. You should go talk to your gynecologist about that. One of the things I love about our group is that we do our own ultrasounds. So some practices, you go to a radiology department or you have a sonographer that comes in and does your scan, and they're not supposed to tell you anything. They're just getting the images. And if you're anything like me, I would be looking at their face, wondering, like, do they look concerned? Do they look happy? You don't know what's going on until you get that consultation and you go over the results. But Dr. Donlon and Dr. Cook and I, we all do ultrasounds ourselves in the office. So when you're concerned about these things, we're doing your scan. We're pointing stuff out to you at the time of your appointment and explaining them in real time. And that's really helpful. Also, from a pain standpoint, if you're having pain when we're pushing on a fibroid or an ovarian cyst, that can be very telling too, because if that's reproducing your pain and we know that's exactly what we're looking at, that can be helpful.
As a woman that gets consultations herself, I have to say that is so awesome. That's like to not have to go somewhere and have that and then wait and then hear from you. That's huge. That's really cool. Thank you for doing that.
Now we talk about self-care all the time. I feel like women take care of everybody else and we take care of ourselves last. And a lot of us think that self-care is selfish. It's not. Self-care is necessary. You have to take care of yourself so that you can take care of other patients and the other people in your life. one of the things that a lot of times women do is they wait years before they get treatment or any evaluation. About a third of women will wait more than 5 years. And because they feel like they don't have the time, or they're taking care of everybody else and they're not going to take the time to see if they have an issue. 80% of women almost, they're worried that they might need a surgery, have long recovery time. Patients might be worried that we're going to tell them they need a hysterectomy, and maybe that they don't want that. Maybe they're not done having children. Maybe they are, but they just don't want to go through a major surgery like that. The important part is to come see your gynecologist so you can be evaluated. There are lots of treatment options. I always say hysterectomy, that's kind of our trick in our back pocket that we can use if all else fails, but that's not where we go first for most patients. And so what I'm truly excited about, and Dr. Donlon and Dr. Cook are too, is that this is a great new treatment modality for those intramural and subserosal fibroids that we can't get to from that lighted camera inside the uterus. And it's this incisionless, non-invasive procedure with minimal downtime. And that's really what our patients are looking for. So don't be scared about what we're going to say. Just come in and be evaluated so we can talk to you about the actual treatment options that exist. And with that, Dr. Donlon is going to talk about different treatment options for fibroids.
Yes. So, like Dr. Adkins said, I would just echo, it's really important that you come in and you start talking with us about what symptoms you have that we could be finding are related to fibroids. And there is a whole host of treatment options that have been historically available and are still available, and including adding Sonata in as a really excellent new, again, minimally invasive, low recovery time option. So I'm going to go through some of the treatment options that we've done in the past before we had something like Sonata available. And goals of treatment for everybody is going to be different. So choosing these options is really going to depend on a patient's goals. So we need to address what symptoms are they having that they are hoping to improve. Are they trying to preserve fertility or their option to have pregnancies in the future? Are they looking for something that is going to be definitive or a forever treatment of their fibroids, or are they hoping to find something in between? So starting as we go through these next couple of slides, we're going to go from less invasive to the most invasive, which would be a hysterectomy. So starting off with medical or hormonal therapy, there are lots of different medical options that can treat fibroid symptoms, and some of these options will shrink fibroids as well. So typically these fall into medications that are going to work somewhere in your hormonal axis. Fibroids are hormonally sensitive masses, so they often will grow in your premenopausal years as a result of your natural ovarian hormone production. So things as simple as birth control pills or Depo-Provera injections can help with the bleeding symptoms. Some of these treatments may shrink the fibroids, but often these treatments mostly just work on symptom management. Advantages are that they do preserve the uterus. It's relatively easy to start and stop these treatments. Some of them will have more side effects. Some of these medications specifically will induce basically a brief but reversible menopause. And so they can cause some menopausal type symptoms as they're blocking that hormone function to the fibroid. So women might notice hot flashes, night sweats, and long-term use of some of the hormonal options could increase risk for bone density loss or osteoporosis. So it may limit the amount of time we can use these medications. A lot of women will consider using these medications as a bridge to other therapy. If they're not getting great result with them, they may use them to control symptoms until they can go through a surgery or have the downtime for a surgery. They may use them to try to shrink fibroids before a surgery. One of the disadvantages to medical therapy is that fibroids will not be completely resolved as a result of these. And once you stop these medications, the fibroid symptoms may resume, the growth of fibroids may resume. Moving on, we're going to start talking about some procedural things that can affect fibroids or can address fibroids. Dr. Adkins started briefly touching on one of these, which is doing a hysteroscopic resection of a fibroid. So what this means is we are doing an incisionless procedure. We're going all through the vagina and cervix to access those fibroids that are affecting the uterine cavity. Again, we're only going to be able to treat fibroids that are somewhat in the uterine cavity, but these are the ones that typically are affecting bleeding as one of the main symptoms. So it usually requires anesthesia. You put a camera in, you distend the uterus with some fluid, and you can see the fibroids and then pass an instrument through that camera and resect the fibroid. This can treat about 20% of the fibroids, again, the ones that are affecting the uterine cavity. Sometimes these procedures have to be done in a staged approach. So sometimes you cannot resect the entire fibroid in one procedure, and you may have to get part of it and then come back 4 to 8 weeks later and try to go after the rest of the fibroid, because a patient's body may not be able to tolerate a long procedure when we're using this fluid media in the uterus. A lot of patients will end up needing another one of these procedures down the road. So even if you get a complete resection of a fibroid, you will often see that a subset of these women will need another resection in the next 5 years. I have a patient specifically who I know has undergone 3 procedures in the last 5 years for either new fibroids or a fibroid that we couldn't fully treat because part of it was in the wall, and it keeps pushing back into the uterine cavity and causing problems for her. The next treatment that we're going to talk about is something called uterine artery embolization. This is actually a procedure that is not done by the gynecologist, but we would refer you to an interventional radiology team. And what's happening with this procedure is the radiologists are accessing your pelvic blood vessels, usually through the groin, and they are going to try to target the blood vessels that feed the fibroid and inject some material into those blood vessels to basically block the blood flow to the fibroid, which will hopefully help them shrink over time. It may require an overnight hospital stay for pain control with this procedure. We do sometimes see women go through a syndrome afterwards within a few weeks called post-embolization syndrome, where they may develop pain or fevers or nausea and vomiting as a result of the significant inflammatory reaction that's happening as these fibroids are shrinking off and losing their blood supply. It is a shorter recovery than something like hysterectomy. And again, it doesn't completely resolve the fibroid. It will shrink them, but these fibroids may resume again, or they may grow back. Another consideration with this procedure is there's limited data on pregnancy afterwards. It's not contraindicated to have a pregnancy after this procedure, but there's not a lot of data in women. There's not a lot of number of pregnancies available in women who have had a pregnancy after this procedure. So while overall pregnancy outcomes after this procedure look pretty similar to a otherwise normal pregnancy, we just don't have a lot of data to counsel women on how their pregnancies may do after this particular procedure. And one other concern with this procedure related to fertility is there is some concern that sometimes the blood vessels that also feed the ovaries could be partially blocked off with these particles that are trying to hopefully just target the blood vessels going to the fibroid. But you could have some reduction in time of ovarian life, which could affect fertility or cause earlier menopause. And again, there's not a lot of data to suggest whether or not that occurs, but that's one concern that people may have with this procedure. Moving on, you can do surgical procedures called myomectomies, which means we surgically try to remove the whole fibroid. Again, depending on size and location and just surgeon experience, this procedure can be done through an open or larger abdominal incision. It also could be done with a laparoscopic or robotic approach where you have several smaller incisions. This procedure, again, preserves the uterus. You do have to undergo anesthesia. You may need anywhere from 2 to 6 weeks of recovery at home, depending on what approach is taken with the procedure and your abdominal incisions. With this particular procedure, depending on how much of the uterine wall we have to cut into to remove the fibroid and then reconstruct the uterus, most of these women need to deliver future pregnancies by cesarean section because it is often not safe to go through labor and vaginal delivery if the uterine wall has been significantly affected by this surgery. And again, the fibroids could come back after this procedure. And so a small subset of women may need additional procedures on fibroids in the next few years. And then finally, and a absolutely definitive approach, but certainly the most invasive, is just undergoing a hysterectomy for fibroids. The hysterectomies can be done through multiple routes, laparoscopic or robotic with small incisions. Open procedures, if we have a really enlarged uterus, Dr. Adkins touched on earlier how we describe these sometimes on based on how the uterus is responding in growth and comparing it to what a pregnant uterus would be like. So if we have somebody that we say has a uterus that's about the size of a 20-week pregnancy, that's often going to be too large for us to do a hysterectomy through a robotic or minimally invasive approach, and that woman may require a larger incision on her abdomen to fully remove the uterus. Historically, a lot of hysterectomies were done with an all vaginal route with no abdominal incisions. When fibroids are present, this is often really difficult because the uterus is often too enlarged to get good access to treat the fibroids, or excuse me, to do the hysterectomy that way. This does end future childbearing without the uterus in there. It will definitively treat the fibroids, but again, it does end fertility for women. One question that we commonly get on hysterectomies is whether or not that causes menopause for women. And I think women commonly think if you've removed the uterus and they're no longer having periods, that they are in menopause. And that's actually not the case for most of the time that we're doing a hysterectomy. So with hysterectomies on younger women, most often women under 50 years old, we usually leave their ovaries in. And your ovaries are what drives menopause occurring. So when the ovaries start to naturally die off and stop producing hormones again around age 50 or the early 50s, that's actually what menopause is the time of life when we stop making ovarian hormones. So even if somebody goes through a hysterectomy for fibroids, they often will not go through that hormonal menopause until they would have most likely gone through it in their life naturally anyways. And we'll move on to Dr. Cook to talk about our new treatment, Sonata.
Thank you. That was so comprehensive. Thank you for not only the explanation of what fibroids are, but like how we have historically been able to treat fibroids. So as Dr. Adkins kind of suggested, this new Sonata treatment is a great tool in our toolbox for treating fibroids. So Sonata is also incisionless, similar to the hysteroscopic approach. So no cuts or incisions on the skin of the belly. Certainly it does preserve the uterus. So we don't remove anything. There's no specimens that are obtained. If you would have, say, a hysteroscopic removal of a fibroid, those tissues usually go to pathology for review, and there's some sort of specimen. With the Sonata, that is not the case. It actually, the surgical center where I am performing these Sonata procedures, our anesthesiologists are typically giving a general anesthetic, and that's just because they feel more comfortable knowing that our patients will be relaxed and not have any kind of like awareness or memory of the procedure. So I think the whether or not the general anesthetic is provided is really determined by the anesthesiologist who is there for that case. But it certainly does not require an overnight stay. These patients are going home from our outpatient surgery center. Typically, they are going home with just Motrin or Tylenol and doing very well with that for pain control. Generally are back to their normal activities within a few days. There are certain fibroids that are more amenable to this type of procedure. So there is a certain size. So fibroids that are greater than 10 centimeters are generally not appropriate for Sonata, but those are not very common. Most of the fibroids that we're seeing are smaller than that and are amenable to this procedure. And as Dr. Donlon suggested, there are hormonal treatments that you can actually give prior to the procedure to shrink the fibroid to a size that is going to be able to be treated with a Sonata. We'll go to the next slide.
Yeah, Dr. Cook, we actually have a question that came in that is related to size.
Okay.
Is a transmural myoma of 9 by 12 by 13 centimeters a fit for Sonata?
That one would be a little bit large. The 10 centimeters is kind of the largest. So the Sonata, and what we have a little animated photo here, but what happens with the this procedure is there is a handheld device that has an ultrasound tip attached. And when you insert this device into the uterus, you can see the fibroids. We start by mapping the uterus, and so we can see exactly where the fibroids are, starting at 12 o'clock and rotating around. So we know exactly how many fibroids there are. We can actually stop the frame and measure those fibroids. And each zone of the fibroid takes a different amount of time to complete the ablation. So a 10 centimeter fibroid you would do in different quadrants, so they would kind of overlap. But a 13 centimeter fibroid would be a little large for this procedure. So unless you could shrink it down with maybe some Lupron ahead of time, the Sonata might not be the right approach for the 13 centimeter fibroid. We're going to go ahead and show this. It's a 2, maybe 3 minute animated video, and then I will go back and kind of explain it a little bit more.
The innovative Sonata system combines real-time intrauterine ultrasound with radiofrequency energy to provide an incisionless, uterus-preserving treatment for women with symptomatic uterine fibroids. The Sonata treatment device is inserted through the vagina and cervix and into the uterus. The intrauterine ultrasound probe allows the physician to survey the uterus and locate fibroids. The physician uses the intrauterine ultrasound probe to target specific fibroids. Graphics are displayed on the ultrasound image to guide the operator. No manual measurements are required. The red ellipse represents the ablation zone, and the green ellipse represents the thermal safety border. The thermal safety border must stay within the serosa at all times during the procedure. The operator adjusts the size and depth of the ablation zone using the purple joystick on the handpiece. The introducer is advanced to the center of the fibroid, and the operator uses the purple joystick to align the smart guide to the introducer. The treatment device is rotated to confirm safety. The physician confirms that the thermal safety border is within the serosa using the gray button on the handpiece. Needle electrodes are deployed into the fibroid, and the treatment device is rotated again to confirm safety. Radiofrequency energy is delivered. Ablation times range from 1 to 7 minutes depending on the size of the fibroid. The needle electrodes and introducer are retracted to allow for additional ablations or removal of the treatment device. 50% of women return to normal activity by the next day. The ablated fibroids shrink over time, and most women experience a reduction in symptoms and heavy menstrual bleeding within 3 months.
So that's a nice animated depiction of the procedure, and I would echo that the fibroids do show up very easily with this device, and as we mentioned before, each of us are trained with ultrasound, which has made this procedure actually a little bit easier for us to pick up, because we already know what the fibroids look like and how to find them. So the big difference in this procedure versus, say, that uterine artery embolization procedure that Dr. Donlon was describing, when people have that embolization procedure, you're actually blocking the blood flow to the uterus, and that's called ischemic necrosis. So that tissue, that fibroid tissue, is actually dying due to a lack of blood flow and a lack of oxygen. And that's what causes more pain with that type of procedure. This type of ablation is different because of the radio frequency energy. It causes a coagulation of that fibroid tissue. So it's literally burning the tissue so that it disintegrates from a coagulative nature. So that's why it's less painful. I will say I've had a couple patients that have had fairly large fibroids that did need a little something more than just the Motrin and Tylenol. But even with a little, say, oxycodone, they were able to manage their postoperative pain. And even with ice packs and heat packs, within 24 to 48 hours, they were feeling much better. So this procedure it's a wonderful addition to our, again, our toolkit of, being able to treat patients who aren't getting the results they want from the hormonal, either birth control pills or possibly the IUD. The IUD sometimes doesn't even stay inside the uterus because of these fibroids. So, being able to offer this type of procedure that allows patients to get back to their normal activities with minimal downtime and minimal pain and with really impressive results. It's really exciting. We're happy to be able to provide this new and exciting procedure. So Sonata has been around for, well, since about 2018, I believe is when it was originally approved and brought into the mainstream for treatment. It is available in the US and Europe. There are up to 11,000 women have been treated worldwide now with the Sonata procedure. And there are many journal articles in medical journals supporting the safety and efficacy of this procedure. Next slide. And so some of the results in one of the trials that I mentioned in the journal, there was 147 women were followed for 3 years following this procedure. Again, 50% of women are back to their normal activities within 24 hours. 95% of women have reduction in their symptoms, specifically the heavy menstrual bleeding, within 12 months. Almost 100, we'll say 94% were satisfied with their treatment. And about 90% did report improved symptoms. And that's either with the heavy bleeding or the bulk symptoms that Dr. Adkins talked about in the beginning of the presentation.
And I do have some questions that are coming in.
Oh, great.
So I'd love to go through those.
Sure.
So the first question is it recommended to get fibroids treated prior to trying to conceive, especially with a history of infertility? And how long after treatment can someone start trying to conceive?
A great question. There is actually some great new data coming out about Sonata related to its safety and efficacy with having pregnancy following the procedure. And I think we kind of touched on before, there are certain fibroids of a certain size or location that should be treated before attempting pregnancy. And it's, that would be a one-on-one conversation with each individual patient. It's hard to, say a blanket statement or answer to that question, because that's really something that you have to be individually evaluated for and then have that consultation. It's a big decision. Some people can have successful pregnancies with fibroids. So not all fibroids need to be treated prior to pregnancy, but some certainly can be and should be.
Thank you. Another question that's come in, would the myoma need to be below 10 centimeters in size to be eligible for Sonata?
Yes. Yeah, 10 centimeters is the largest. Again, I've done some that are up to 8.5 centimeters. And you just have to be patient. Each in that little video, they showed you the mapping with the red border and then the green safety border. So the largest area that you can ablate is 4.8 centimeters. So again, if you have a 10 centimeter fibroid, you're going to ablate that in probably at least 3 different zones. And the largest area usually takes about 6 minutes to do the ablation. So, a patient who has multiple large fibroids can take up to probably an hour to treat all of the fibroids.
Thank you. Here's a question. would postmenopausal women with fibroids be candidates?
I can feel that if they are symptomatic with their bulk, pressure on the uterus, pressure on the bladder, or pressure on their bowels, or sometimes fibroids, even if somebody has stopped having their menses naturally, fibroids can cause postmenopausal bleeding. So again, when we do the evaluation for what's causing the abnormal bleeding, certainly in a postmenopausal woman, you'd be looking for a polyp or either a precancer or a cancer. So that would require an endometrial biopsy prior to the procedure, just to make sure that you were excluding any and all other causes for that postmenopausal bleeding. But if after that evaluation you think that the fibroid is the cause of that bleeding, then the Sonata could be an appropriate treatment.
Thank you. And Dr. Adkins, going back to some of the symptoms that we talked about, a question that just came in is, can fibroids cause frequent urination and cause bladder pain and sensitivity?
Especially if the fibroids are on that front side of the uterus that presses against the bladder. Yes, that can definitely cause frequent urination, similarly to when someone's pregnant and they go to the bathroom all the time because their uterus is larger and pushing on that bladder. So that could definitely cause some bladder issues. And if they're on the back side of the uterus specifically, that can cause more issues with the bowels and constipation or difficulty eliminating stool. So yes, depending on where they're located and what they're pushing on, that can definitely cause discomfort.
Thank you. Dr. Donlon, talking a little bit about some of the different treatment options, I've had two questions that came in. The first is, this woman had a fibroid removed last December, but is still having heavy bleeding. Should she try Sonata or go for a hysterectomy at age 45?
I think that definitely, depends on the evaluation of what we're seeing remains in the uterus. So the first step for that patient would be to repeat an ultrasound and see, are we finding a recurrence of new fibroids? We will commonly find when we go in for either a hysterectomy or a myomectomy that we were expecting maybe 1 or 2 fibroids, and we'll find many others that weren't easily visible on ultrasound. So I think it really depends again on an individual patient's goals, but the first step would be to ultrasound again and see if we can assess if there are still fibroids present, and whether or not that person is just really looking for complete definitive end to the possibility of fibroids, or something that is hopefully going to give them a good treatment result but less downtime, like Sonata. So definitely an individual decision, but you probably would be a candidate for either procedure.
And the second question that came in is, I'm in my mid-40s, continue to take birth control to control heavy periods and frequent urination are my symptoms. It has been manageable with the pills. If I were to continue taking birth control pills, what are the pros and cons, and what should I consider as I head towards 50? Or how would other hormonal treatments be different from birth control for someone in their 40s?
I can feel that one.
Thanks, Leah.
Yeah. So with the average age of menopause being 51, 52, as you go towards menopause, the fibroids feed off those monthly hormonal changes. So typically, if you can get to menopause, your symptoms aren't going to get worse. They're going to you're going to stop bleeding, and the fibroids are going to stabilize in size or maybe get a little bit smaller. So if your bleeding is controlled by the medication and you're fine remembering a pill at the same time every day, then that's reasonable to avoid surgery. But if that's an inconvenience, you can definitely talk to your doctor about other treatment options. As far as the frequent urination, though, the fibroid is, once you hit menopause, if it doesn't significantly shrink, that could continue. Even though you don't have periods anymore, you continue to have that frequent urination as that fibroid pushes on the bladder. So when we talk about the bulk symptoms, that's referring to the size of the fibroids and what those fibroids are pushing on. So if it's pushing on your bladder, the birth control pills can maybe stabilize that size. Once you stop bleeding, once you hit menopause and you stop the birth control, that size might still push on the bladder and cause those symptoms. So it really depends the location and the size and how severe your symptoms are.
And another symptom question. Can fibroids contribute to chronic constipation?
Yes, they can. I find that a lot of women don't drink enough water too, because it's hard to find time to drink water. And if you drink water, it's hard to find time to actually go to the bathroom. So that's what I would tell my patients first and foremost, is make sure you're staying well hydrated. But again, if those fibroids are on the backside of the uterus, which is right next to the rectum, which is where all your stool exits, it could push on that and make it harder to eliminate your stool.
Thank you. And Dr. Cook, a question that came in is, what is the likelihood of the fibroid returning or regrowing after having Sonata?
So I just was asking this question the other day when I was in the OR, and I said, how many patients have had a repeat Sonata procedure? And the team that I was talking to has been doing this for 5 years, and they've not had any repeat procedures. So it can be done. I will say that the fibroids that have been ablated usually will not grow back to the point that you would need a repeat Sonata, but certainly patients who have fibroids are predisposed to growing more in different fibroids. So potentially, if you had a new fibroid that grew over time, another Sonata procedure to target a different fibroid could be done. So, but there are some fibroids, because we're putting that ultrasound transducer inside the uterine cavity. So some of the fibroids that are farther away towards the outside wall of the uterus, they're a little bit, they're just farther away to reach, and our electrodes can only deploy, so far. So we always have to stay inside our safety border. And so, you can ablate and treat part of the larger fibroids and then see how much shrinkage there is. And then if you need to go back and get a little rim or a remnant of that fibroid, that could be done at a future time.
And
Dr. Cook was talking about the safety border.
Yeah.
And another question popped on about if that radio frequency affects the surrounding areas and organs. And yes, it can. And that's why we have the safety border. So it was maybe a little bit hard to see in the video of the procedure, but there's a green border and a red border. So when we're ablating the fibroids, we stay well within those two safety borders, so that we're entirely within the uterine muscle, and we're not extending outside to the uterus where we would get injury to the bowels or the bladder.
In fact, there have not been any reports of injury to surrounding organs because that safety border is so wide, and we're always doing our safety check. So we know when we're deploying that radio frequency energy that it's concentrated right on the fibroid and not going to be spreading outside of the uterus.
And one thing that's really unique and neat about Sonata is the fact that we're using an ultrasound handle or an ultrasound probe as we're ablating. So there have been other treatments that involve some type of ablation of fibroids that have been evaluated or trialed in the past. There's other types of ablation procedures that we do on the uterine lining. If you've ever heard of endometrial ablation, some of the device names are called Minerva or Novasure. And these procedures are done more blindly. And so Sonata is really unique in that we have an ultrasound there and we're looking at that fibroid with the safety border very easily visible, which makes it really, really unique and able for us to keep that safety ablation border well away from the serosa, again, the outside of the uterus where the bowels would be next to it, or for women who want future pregnancy, we also make sure to keep that safety border away from their endometrial lining so that we don't ablate or burn any of the uterine cavity, because we want to preserve that endometrial lining for future pregnancy implantation. So that ultrasound piece is really unique to this procedure.
Yeah, and we've heard from physicians that sometimes when they go in, since there is an ultrasound camera on the tip of the device, they're able to see fibroids in the patient that they didn't necessarily see on the ultrasound or know that they had going into the procedure.
And some people may have heard of a similar procedure that is approached laparoscopically as opposed to, we're not using a hysteroscope, but we're doing this through the transcervical into the cavity of the uterus, which makes it a lot safer procedure than approaching laparoscopically. The laparoscopic approach, kind of like the robotic approach, requires incisions on the abdomen and poses an increased risk for damage to intrauterine organs like your bowel and your bladder. So this procedure is, in my opinion, much safer and a better approach than that laparoscopic ablation.
So the important thing, we were lucky enough to get to have an hour of time with Dr. Donlon, Dr. Cook, and Dr. Adkins from Avina Women's Care. And we want to make sure that you all are able to schedule a consultation with them. Something that we always talk about when we're doing these patient education events about fibroids is make sure you're finding a physician like these three physicians that are talking to you about all of your different treatment options and making sure that they hear your interests of treatment and put together a plan that works best for you, because every woman is different, every fibroid is different. And finding physicians like these that are willing to hear what you have to say and to tell you all of your different treatment options are very, very valuable. So to be able to schedule an appointment with any of the three of them, the link is in your chat. It's also up here on this screen. Make sure if you're going just to their general website that you're looking at the Dublin Bradenton Avenue location. That way you can get an appointment with either three of them through the form that you submit through the request an appointment button. Anything else that any of you would like to say? And I think our questions ended, which we had a lot of them, which is great. So I thank you all for your participation as well.
We have 3 locations. So with that Bradenton Avenue in Dublin, we also have a location near Riverside Hospital on Olentangy River Road, and one in Westerville on Polaris Parkway, right behind the Winking Lizard where Cleveland Avenue intersects. There are 2 Avina locations on Polaris Parkway. I believe ours is that 460?
460,
yes.
460.
Cleveland Avenue.
Polaris Parkway. But if you call that number, the 459-1000 number, you can be scheduled at any of those 3 locations.
Thank you. And we will send the link in a follow-up email, as well as some stories from women who have had Sonata and wanted to share their testimonial of how their life had changed from living with fibroids to after having the Sonata treatment. So we will send that as a follow-up email as well. And again, be sure to schedule a consultation so that you can see any of these 3 physicians and see what procedure or if Sonata is right for you. Thank you all very much and have a good evening.
Thank you so much.
Thank you.
Bye.